Hello, thank you for joining us in this interview today. My name is Fabien Lareyre. I'm the head of the Department of Vascular Surgery at the Hospital of Antibes in the south of France, and I'm the Secretary General of Vascinet, ESVS. I'm a member of the social media team for the PVI, and today we are very honored to have with us Professor Peter Schneider, who is a renowned professor at the Department of Vascular Surgery in San Francisco, University of California. So, Peter, you're also part of the organizing committee of the PVI that will take place in Paris in December. So please feel free to introduce yourself as well.
Thank you so much, Fabien. Yes, I'm Peter Schneider, vascular surgeon. I've had a long-term interest in carotid disease over the course of my career. As was mentioned, I'm a vascular surgeon at University of California, San Francisco, but I have spent most of my career actually in Honolulu, in Hawaii, and carotid disease is quite common there, as well as CLTI. So over these most recent couple of years, as the PVI meeting has grown, and then there are multiple activities associated with the meeting. One is putting together an update book each year of the most recent studies, and so I've been fortunate enough to be asked to put together an update each year on carotid disease. And it's a very succinct presentation in the sense that it would give the reader, this would be terrific for fellows or for practicing doctors who are very, very busy, to get a look at what are the latest, most important studies without having to cull through thousands and thousands of papers in the literature. So this year I chose multiple studies to be added to the book, and I'm excited to tell you a little bit about them.
Thank you. Thanks, Peter. So can you just give us a short overview of a clinical trial that you chose?
Yeah. So, well, as I mentioned, there are multiple new studies this year, including both asymptomatic and symptomatic disease, and also new technology. So, for example, the latest in flow reversal, like TCAR or covered stents, which I know in Europe you've had covered stents for carotid stenting for some time. In the U.S., we have not. But to get into the U.S., they have to do new trials, and with the new trials comes new information, and of course adds to the experience that has been undertaken in Europe. This is now with the two different covered stents, and the most recent study is called Sea Guardians, which is with a mesh-covered carotid stent placed from the transfemoral position. Other studies that have been amazing this year include some topics that we don't frequently talk about. So, for example, cryptogenic stroke, a very interesting study in patients who have who have highly friable, very soft plaque in their carotids, but they don't have 50% stenosis, and they come in with a stroke that we call unknown origin. But then they go back to do complex morphologic imaging of the carotid stenosis and find that it was the likely source, a so-called, again, cryptogenic stroke. There have been other studies on that have completed that we've known about for some time, but is always interesting to hear the punchline. So the ACST2, for example, asymptomatic disease, everyone treated with best medical therapy, but some patients randomized to CEA, some to transfemoral. And of course, in that study, the CEA patients had a lower risk of stroke and death. And that, I think that was anticipated. One study I'd like to highlight this year comes from a growing body of data that I think is highly interesting, and it's about dementia and cognitive decline in patients with otherwise what we would call asymptomatic carotid stenosis. And the study I wanted to highlight comes from, of all places, an insurance database of patients that are diagnosed with asymptomatic carotid stenosis. And then because in these types of databases, and again, the European continent is very familiar with these because you have so many terrific databases in the various countries of the EU. This is a large insurance database in the U.S. looking at several 100,000 patients, and what it shows is that patients who have asymptomatic carotid stenosis, even those on best medical management, those who do not undergo repair, are at a higher risk for the development of dementia, diagnosis of dementia, and cognitive decline. Of course, in a study like that, you have certain disadvantages. You don't necessarily have the ability to drill down to the patient level data. And you have also the possibility that, again, because it's a large data study, that some of the diagnoses could be a little bit incorrect or imprecise, these kind of things. But when I look each year, what I see is a steady and stepwise and dramatic increase in the association between asymptomatic carotid stenosis and dementia and cognitive decline. This is something that I did not think was too important when I first heard about it. I just thought, oh, the people, the carotid experts, are looking for a new thing to complain about or to try to say is important. And I just really didn't think it was. And yet, although this study is not conclusive, like most of the others are not, it's actually quite a challenging area to study because cognitive decline is very, very difficult to quantify. There's so many different tests that can be employed to assess a person's cognition, and so because of this and the variety of tests, and also the longitudinal nature of this problem of the decline, it's not a binary on-off switch. It's a sort of a progression over time. And yet, like I said, it's just another of these studies. And I don't know what kind of study or which study it will be, which will help us to get to a point where we can say, aha, this needs now to be in our guidelines. It needs to be on the top of our concerns. But I see it steadily mounting. So I thought it was interesting, and I would mention that for this year.
So if you have to choose only one study that could impact or reshape our current guideline, which one will you choose?
Well, I don't think there's anything this year that's going to perfectly change the guidelines. Although I have to say a mention of CREST-2, which is a very large study in the United States of asymptomatic carotid stenosis, and CREST-2 is going to report out in 2026. That will, in my opinion, that will definitely influence the guidelines, regardless of what the results are. If it shows that any type of repair is not helpful, that will have a big impact because it's a large study with all the, what I would call all the associated factors of a randomized trial that's well done in multiple centers. If it shows that repair is helpful, but not in everybody, just in certain subgroups, that may play a role, this kind of thing. So, but in terms of what we have this year, I think I see the cognitive decline study as yet another in an additive stream of studies that eventually will affect the guidelines. And like I said, ACST2 came out, but that will reinforce existing guidelines that favor CEA over transfemoral stent, except in situations where CEA is not your first choice because of the patient's risk factors, etc.
Yeah, of course. And now we are talking about AI, artificial intelligence. It's a really burning topic right now. So how do you think AI would affect, the carotid disease? What could be the application of AI in this topic?
Yes, this is a really, really good question, Fabian, because I think one place where AI is particularly strong is in the analysis of imaging. And I know you're the expert in this, so you will have to tell me if I'm on the right track. But I see carotid disease, even though the clinical syndromes, we teach the clinical syndromes right out of the textbook, focal motor, TIA, or small stroke, etc. And the clinical part is very, very important. Um, the clinical part is becoming um, very, very much dominated by imaging. I think carotid disease going forward is going to be so heavily influenced by imaging. I believe that there probably are patients um, who have what we call cryptogenic stroke, where the patient comes in with a stroke of unknown origin, and they look at the carotid arteries and they appear not to be severely stenotic, but then with the advances in imaging that we have, and there was a nice body of literature about this past year of looking at the plaque itself and associating it with its propensity to embolize. And I think using AI to do plaque analysis, using AI to look at whether a candidate might be a better whether a patient would be a better candidate for maybe a stent than a CEA, for example, because of the location of the bifurcation, how high it is, or whether they have too much calcium for a stent. All of these things could really be looked at by AI, maybe not for the final answer, but to give us directionality of which ones are the best candidates. I think also we could use AI for cerebral imaging to look at the size of the stroke. Right now, we just estimate it. When a patient comes with a stroke, we say, well, if it's too large a stroke, maybe you should wait longer than the usual period. But then in terms of assessing the size of the stroke, it's not very well quantitated, in my opinion. And I think these kinds of things could be further researched. How large is too large? And AI could really help us with that. And then I'll just throw in one last thing. I think AI helps us everywhere with medical management, with helping to ensure that our patients are on medical management and doing chart surveys and these kind of things. And medical management is absolutely essential to the success of all of your treatments for carotid disease and for the best health of these patients. So I think AI could help there as well.
Yeah, you're completely right. Imaging, that's the most important for now, where AI tools have been developed also to develop predictive model using a large database like you have with the VQI or with VascuNet within the ESVS, and it will come soon. And yes, this is a really important point that will shape the future, even for the design of clinical trial. So I'm sure for a carotid trial, maybe we will use in the near future this kind of tools, and I will be very happy to see that within the next few years. I would just like to ask you a last point for this interview. Because we spoke about the new trial, the new studies, AI, but it could be great also to speak about fundamental research. So what have been done so far in the field of carotid?
And in the field of carotid, with respect to AI, I think there are several groups trying to use AI to help to understand plaque analysis. Plaque is so heterogeneous. We know this because as surgeons, we see this plaque when we do a CEA, and correlating the the plaque and its potential risk to the patient is really what understanding asymptomatic carotid disease is all about. I'm not interested in doing a carotid repair on an asymptomatic patient that has a low-risk plaque. But we spend so much of our time trying to figure out which ones are low risk and which ones are high risk. I think AI could solve this. I really do. And I think, and there are several groups that are working on this. There's a group up at the University of Washington that has advanced imaging, and they have been doing plaque analysis for some time. There's also a group at University of Maryland. At Washington, it's Tom Hatsukami, who's a vascular surgeon that has finished his practice, and now he's a full-time researcher. At University of Maryland is B.K. Lau, also a vascular surgeon, is one of the top organizers of the CREST-2 study, which I mentioned. And he's also been quite involved in the use of plaque analysis and then using AI to try to move that forward.
Oh, great. Okay. So thank you, Peter. I don't know if you want to add something else regarding the new PVI trial book that will come.
Yeah, well, the new trial book is, I'm fortunate because I get to see it ahead of time. It's really a robust update in every part of our practice. So this includes, for example, aortic updates from Tim Resch. It includes PAD updates. Jan Gafik is involved in that. It includes dialysis. It includes venous. It's quite robust, and carotid, of course. But it contains all the different areas that we're interested in, and because somebody on our behalf has gone through the literature to say, okay, what are the most meaningful trials? What are the most interesting trials? But kept it, like I said, succinct, one page on each, so that in your moment of whether you're watching the young kids or whether you only have 10 minutes before your next case, you can look in there and get a quick brief update. So very, very exciting.
Yeah, thank you. Very pragmatic, very good format. So
Agreed.
thank you very much for this insightful discussion. Thank you for watching us, and we are looking forward to welcome you in the next PVI Congress in Paris in December, and we will share experience and knowledge with all renowned experts in the field. Thank you, Peter.
Thanks, Fabien. Thanks for your time, and it was fun to catch up.
Thank you.
Bye-bye.